All right, we're live.
All right, welcome back after our short break. So today we're going to look at a report that we asked from the Green Mountain Care Board. One of the concerns that we have is about equitable provider reimbursement to help stabilize our whole medical environment in our healthcare world. So, and we continue to work on that in many areas, whether it's our DAs, our SSAs, our primary care docs, and others. So this is a report that we asked of the Green Mountain Care Board, and it looks at hospitals, but also at other providers. So Robin, Elena, and Sarah, thank you for each of you for being here. So just so you know, Sarah, have you been in before this year?
I have not been in this year.
Well, then we should let you know that you have some new senators to the committee, new to the committee. Senator Hardy from Addison County, Senator Hooker from Rutland County, and Senator Terenzini from Rutland County. So we're surrounded by Rutland County, and Senator Hardy and I just try to hold up the rest of the world. All right, so, thanks for being here. It would be helpful for you to introduce the report, and we have two things on our webpage, but they look like they're the same, and one says part one, but the other one looks like it's the same thing, but you can help us through as we
can help you through.
All right.
Sure. So Senator Lyons, I thought before we jumped in, perhaps Sarah and I would introduce ourselves. I haven't been into your committee yet this year either.
All right.
So I thought we'd start with that, and then I'll tell you a little bit about what we had planned today after talking with you on how to approach it and the difference between the two documents. So my name is Robin Lunge. I am one of the 5 members of the Green Mountain Care Board. I was appointed about 4.5 years ago by Governor Shumlin. So I'm nearing the end of my 6-year term. Prior to working on the board, I was the Governor Shumlin's point on healthcare reform for his administration. And prior to that, I actually worked at Legislative Council for close to 8 sessions, actually. Over the course of 10 years, I did take a brief hiatus and went to DC, which I quite frankly hated. So came back to the legislature, came back home. I'm from Vermont originally. And prior to working at the legislature, I was a practicing attorney at Vermont Legal Aid, and I'm an attorney by training, and I also have a master's degree in healthcare delivery science from Dartmouth. So that's a little bit about me and what's starting to feel like a long career in healthcare policy and regulation in Vermont. But I'll let Sarah introduce herself, and I believe you saw Elena yesterday. So Sarah, why don't you go ahead?
Thanks, Robin. So my name is Sarah Kinsler. I'm the Director of Strategy and Operations at the Green Mountain Care Board. I've been with the board for coming up on 4 years now, but it's flown by. Prior to the board, I staffed Vermont's State Innovation Models grant, which Robin will briefly mention in today's presentation. And I came to Vermont from the National Academy for State Health Policy, where I worked with states all over the country on best practices in primary care and patient-centered medical homes, as well as safety net provider issues, so mostly federally qualified health centers. And I also have a master's from Dartmouth in public health.
Great. And then, of course, we have Elena Barabee, who is, Elena, you should say your title because I'll mess it up.
Health Systems Policy at the board.
Yeah, great. So thank you very much for having us in today to start to talk about our report on regulated provider reimbursement. So you have 2 documents in front of you because the report that we submitted is a PowerPoint in the form of a PowerPoint presentation. And that report really does a soup to nuts review of background and some options around provider reimbursement. However, for today, what we discussed with Senator Lyons was really to to do an introduction and background, so ease you into a little bit. We really did a deep dive into regulating provider reimbursement. And so what you do have a very dense and thorough consideration of 3 options with sub-options. So what we were planning on doing today was dipping our toe in, talking about the background, the information, and then ending with just a very high level of the 3 main options. And then we hope that you will have us come back to do a deeper dive into 1 or more of the options at your chair's pleasure. So that's really what we were thinking about. So the second document is really a shorter version that really focuses more just on the background. We've also tried to add a couple more summary slides to really ease into it. So with that, Senator Lyons, if you're ready, I'll jump right in.
Oh, please, you're in charge. Go right ahead, please. Thank you.
Okay, great, thanks. So Elena, if you could do the next slide. Cool. So this first slide goes through the statutory language in Act 159 of Section 5. And really, what you asked us to do was build on prior reports that both the board and actually my office in my previous role had worked on relating to pay parity and provider equity. And so what we were trying to do is to take those previous more theoretical reports and give you realistic implementation options. We don't have recommendations in this report. We really have a soup to nuts set of options for you to think about and decide how to move forward with. So in approaching this report, we really tried to look at provider reimbursements in the current regulatory and policy environment, both at the state and federal level, and balancing the various considerations that you outlined in the statute, but also the current regulatory environment, which is focused on both cost containment as well as provider equity. And certainly one of our themes this morning will be talking about how some of these policy goals really are in conflict with each other. And so we all have to really think about how the best way is to balance these goals, because unfortunately, we really can't come up with a regulatory process that works and doesn't have any really negative consideration. There are pros and cons to each option, and part of what we want to talk with you about is how you think it's best to balance those. So Elena, next slide. So we wanted to start the discussion with trying to really lay out some questions that we should be thinking about as we approach consideration of provider reimbursement regulation, and really focusing on what are the key problems Vermont is trying to solve. Certainly cost containment and value-based care have been central to Vermont's health reform strategy over the last decade. And certainly as part of that, we need to start to consider how we would prioritize both provider sustainability and equity, which necessarily involves increasing provider reimbursement in some instances, while balancing consumer affordability and access, when we know that Vermont commercial consumers in particular are having trouble affording their health insurance and access to care through their deductibles and other considerations. There's also different ways to define sustainability and reimbursement equity. We may have some hard choices facing us in Vermont as a small rural state around sustainability and equity, and really how to prioritize different sectors of the provider community. And certainly when you hear the Act 159 Section 4 report, which you'll be getting an update on, I believe, next week, but the report itself is due in the fall, that will significantly expand on the concept of sustainability, particularly in the hospital sector, which you asked us to focus on in that report. And then lastly, Vermont has, in its healthcare reform, really taken an approach of provider-led reform. Our regulatory authority over the ACO, for example, reflects that. And regulation is by its nature mandatory. So that's another key consideration to think about as we move forward with this topic. Next slide. So I'm going to jump in to the background considerations, and then I'm going to turn it over to Elena. So when approaching this report, we started from the current context, which is specifically a federal and state commitment in moving towards value-based care. However, since the focus of the report was on provider reimbursement, you'll see that the focus is really on how do you deal with the cost component of this equation, and consideration of how to fold in quality or outcome measurement would be a next step. Next slide. So as I've mentioned, the current environment that we have been living in at the federal level is a move away from fee-for-service provider reimbursement to value-based care. And that's a commitment that 3 different federal administrations have maintained. And it really started in 2010 with the Affordable Care Act and the creation of the Center for Medicare and Medicaid Services Innovation Center. And they're in charge of testing new payment and delivery system models, particularly for Medicare. And that has sort of evolved with different changes in the Medicare program, and also with a new focus in Medicaid in particular at the federal level on value-based care. So we're still really waiting to see how that really gets fleshed out in the Biden administration. As you likely know, the HHS Secretary Xavier Becerra was confirmed just last week. And they have also appointed a director for CMMI, the Innovation Center, Elizabeth Fowler. So we do expect that we'll hear more about the Biden administration's approach in the coming weeks and months. Next slide. In addition, Vermont has been focused on moving towards value-based payment really since 2003 with the creation of the Blueprint for Health. And for pretty much the first part of the 2000s into the mid-2000 teens, Vermont was really focused on how to implement the Blueprint, which is, I'm not sure if you've heard about the Blueprint yet in your committee, but certainly that's Vermont's medical home and community health team model. And that's a model that took about a decade to really become statewide. And that was the first movement that Vermont had towards value-based payment and delivery system reform. There is also a big focus under the State Innovation Model Grant. The state received a significant amount of federal funding, which really is what launched our Medicaid and commercial ACO programs, and supported the development of the all-payer model agreement with the federal government. And then after the all-payer model agreement, which I know you heard about yesterday, was negotiated, that really became the most recent focus of this value-based payment reform. And of course, underlaying all of that has been Vermont's longtime Medicaid waiver, the global commitment to health. Next slide. And I'm turning it now over to Elena to jump into more of the details.
Yes. Okay, so controlling healthcare spending, as Robin mentioned earlier, is one of the key kind of goals of the state. And the all-payer model, as she just mentioned, is one of the vehicles through which we seek to do that. So to control spending, there's 2 kind of components that you can tackle. One is unit cost, the other is utilization. So our all-payer model tries to tackle the utilization component. It certainly does touch on cost, but the goal is to really reduce unnecessary utilization, shift to prevention, reduce chronic conditions, and that should hopefully affect spending. The focus of this report is really to talk about that cost component. So it's a more nuanced approach to kind of trying to control that total spending growth. Oops. Okay, so I just wanted to, you've seen this slide before, but focus a little bit more on kind of the key terms that we kind of pulled out and how that shaped the report. So we identified, like Robin said, options that will allow us to improve sustainability of providers, as well as the equitable reimbursement amongst providers. And we'll go into more detail on how we define those specifically, but within the context, most importantly, of value-based care. That is kind of the world in which we are all kind of moving and the momentum is going. So So value-based care, we defined broadly as the efficient and economic delivery of high quality care. So does the policy option move us away from fee-for-service? Does it address utilization issues and promote services where, that improve healthcare? So is it shifting us to prevention like we had hoped? Provider financial sustainability, we define as the ability of providers to consistently cover expenditures with revenues. So those mechanisms for reimbursement, are they sufficient to cover their costs of delivering healthcare? So in looking at the policy options, does it consider a provider level look for solvency and consider payer mix and promote flexible, predictable revenue streams to providers and allow them to kind of maintain those capital investments over time? So not just expenditures on kind of an annual sense, but does it tee them up to be successful to continue delivering services over the long haul? And when we talk about services, and you've asked us to put forth another report on hospital sustainability, we'll talk about that tension about financial sustainability, but also preserving access to essential services in communities. You can't kind of untangle these. So while that was not, we didn't have the time to go deep into that area in this report, we focused mainly on the financial component of sustainability here. So reimbursement equity, again, we took a broad approach, but it could be defined more narrowly. So we looked at, within and across care delivery provider types. So does the option address underlying fee-for-service differential within a certain provider type, or does it between provider types? So for example, between specialist and primary care, for example. And then, as we mentioned, a theme here is the tensions that could exist. So no single option that we present maximizes both sustainability and equity, but some of these options could be layered to address both of those issues and could be pursued simultaneously. However, it's important to note that could add additional complexity, expense, and regulatory burden. So we need to be thoughtful about how that would be done. I'll pause there. Okay. And so access and affordability are two other components, while not identified or called out in the statute, we thought were important considerations and goals of the state. So particularly in rural settings, the reason why we have critical access designation at a federal level is because we believe that access is important, even if it's not efficient or economically, I shouldn't say viable, but so there, you might be paying for some inefficiency to make sure that you have access. So reimbursement is really important. It does not solve the access or affordability issues, but they're certainly intertwined. So we wanted to highlight that here, and that would be an avenue for further kind of contemplation. I'll turn it over to Sarah.
Thanks, Elena. So before we wrap up the background, we really wanted to set the stage and give you some context for digging into the options by providing some background on regulating provider reimbursement. So we defined this as government action to set provider reimbursement methodologies and amounts, which can be implemented either through provider regulation, either at the provider or entity level or at the service level, or through insurance regulation by setting the parameters for payers and providers to negotiate. So currently, provider reimbursement amounts and methodologies are most commonly negotiated between commercial payers and providers in their networks, or they're set by the public payers, Medicare and Medicaid, for providers participating in their programs. Left to the market, these negotiations are influenced by relative bargaining power and market share, as well as kind of historical payment amounts. And then where an ACO or ACOs are present, that's an additional set of negotiations to set methodologies and amount. And I know that you heard a little bit about this from Elena and Ina yesterday. Next slide, please, Elena. Thanks. So there are two primary bases that kind of sit at the foundation of provider reimbursement and on which we build payment models. The first is cost-based, where reimbursement amounts are based on the provider's historical cost to provide a service or set of services. And here the prices are based on actual expenses, sometimes blended with a peer group, or potentially also with other adjustments. And the biggest example here is Medicare's reimbursement of critical access hospitals, as Elena just mentioned. And this is based on each provider's historical, or each hospital in this case, historical costs, because Medicare recognizes that these hospitals are serving very few patients, and that we need to give them a way to pay for ongoing infrastructure and fixed costs. And then the second basis for provider reimbursement is fee-for-service, where reimbursement amounts are really market rates. And these can be set based on negotiated amounts, historic amounts, or a reference payer. And fee-for-service amounts, we wanted to highlight, are not necessarily related to the actual cost of providing services. So they could be far less than the expenses associated with providing a particular service, or far more. And either of these can be kind of rolled up into more complex payment models, like a per diem rate, episode-based payments, or global budgets. But they can also be layered with payment strategies with the goals of improving quality and or controlling spending growth. And that includes growth targets or caps, which limit price growth and growth trends. It includes value-based models, which reward or penalize providers based on performance on cost or on quality. And as Robin said early on in this presentation, we really are looking at the cost and reimbursement side here, but I think quality is something that could get layered onto almost any of these models, and or population-based payment models. Next slide, please. So then we'll kind of finish with this, or at least I'll finish and then pass it back to Robin, with this chart that outlines those three different regulatory approaches and reviews some of the trade-offs. So I'll dig into these each with a little bit more detail. Approaches 1 and 2, again, are provider regulatory strategies. And then the last approach 3 is via insurance regulation. So we'll start with approach 1, entity or provider-based regulation. This sets reimbursement policy for the provider entity based on provider characteristics. And a great example here is our hospital budget review process that the Green Mountain Care Board currently does. And that really looks at expected revenue and expenses for each provider organization. The trade-offs here are that this individual view supports a strong focus on sustainability. And we can also balance factors like payer mix, population served, community characteristics, et cetera, when we think about sustainability and when we think about equity. However, if we're thinking about equity just as paying the same amount for the same service, no matter who provides it, that is much harder to achieve because this kind of process is so provider specific or organization specific, and providers have different expenses and they have unique circumstances. It's also harder to scale an entity or provider level regulatory approach to provider types with larger numbers of unique organizations. So this works in our hospital budget process because we have 14 hospitals. If we had 100 hospitals, it would be much harder to effectively regulate using a model like this. Another kind of benefit of this regulatory approach is that it captures a broader population since it's implemented through provider regulation, which regulates how providers charge for their services, kind of agnostic to payer. Approach number 2 is service-based, and that's where we're setting reimbursement policy for a category of services or for specific services across all provider types and sites. So a hypothetical example here might be that payments for primary care services must increase by X% in a particular year. Another example might be, capping payments for a certain service type. The trade-offs here are that this approach is, very compatible with reimbursement equity or reimbursement equity focus because it sets reimbursement policy for a service type regardless of where care is delivered. That said, it can't consider sustainability in a very nuanced way because it doesn't look at individual organizations and kind of the variation in circumstance and need across them. Like the entity or provider level approach we just walked through, it also has the potential to capture a broad population and a broad kind of percentage or proportion of expenditures, depending on the service's impact, because again, it's based on, it's regulating how providers charge for their services, regardless of payer. And then the last approach, the insurer or payer-based approach, sets policy through the insurance market. So the example here would be to require GMCB regulated commercial insurers to increase payments for primary care services by X% in a particular year. The trade-offs here are that we're impacting a much smaller population. So we're looking here at a subset of the commercial market, which in Vermont is limiting because our insured market is so small, about 94,000 people, and it would not reach self-insured employers. We can't consider sustainability in a nuanced way again here, and the reimbursement equity focus would also be limited because the population is so small. I'll also say, and I think this is something we didn't list on the slides, but the implementation burden on the state, this is kind of like an easier to implement option, so that might be a pro. But lastly, I just want to highlight that if we an offsetting limitation must be made in other services if we want to achieve cost neutrality to premiums. So in plainer language, if you choose to increase to give an increase to one provider sector or to one type of service, and we don't decrease somewhere else, premiums will increase. And now I'm going to hand it back to Robin to wrap us up.
It would help if I was not on mute, I think. We wanted to do a very high level overview of the three options that we have in the report. And then we're happy to take a cue from you, Senator Lyons, in terms of if you want to, at that point, pause and really have a discussion and about the background, or if you want us to continue to do a bit more of a deep dive on the options.
Why don't we just see if right now, see if anyone has any questions about what you presented so far for basic information. Any questions?
Madam Chair?
Yep.
I have a lot of questions and I'm not sure where to even start. So I'm still absorbing a lot of it. So I want to reserve the right for questions or whatever and discussion because this was a lot of information presented pretty quickly. So my lack of a coherent question right now doesn't mean I don't have questions.
Okay, no, you know, this is one of the reasons why we have split the reporting up into at least three different little chapters. And so, yeah, I mean, the fact is that it is new to you, and I completely respect that. So what we'll do is I think we'll go ahead, keep your questions, and we'll come back around. It might be even worthwhile, depending on what our timing is like, to circle back to that first section and go through again and look for questions. So, and this is, and we're going to have to prevail on Sarah and Elena and Robin for their patience and understanding that we may like to look at this again. So, Robin, how does that fit with your?
Oh, that's great. I mean, I think part of the reason why we wanted to really focus on background, because I think once I'll talk through sort of these three options at a high level, but I think because that may help you form your questions on the background, but it's complicated, dense stuff, and there are a lot of pros and cons, and there's no silver bullet. So, you know, I think that does mean there's a lot of different considerations to think about when choosing an option. So let me just tell you what the three options are at the high level, and then we can see what makes sense to you all. So we came up with three basic options, and those are health systems budgets, setting reimbursement parameters, and fee-for-service rate setting. And so each of these options in the report has at least 2 to 3 different looks from both the provider regulatory side and the insurer side. So one of the reasons we wanted to go through that high-level regulatory approaches with you is because you can implement these 3 types of options in different ways. And so understanding sort of the pros and cons of those different regulatory approaches will help understand why the options sort of flow through the way they do. But let me start by telling you what they are. So the health system budget, what that is that would be a regulatory process that would look at setting really a firm budget or cap, essentially, for some part of the health system. It's not necessarily the entire health system. So for example, the hospital budget process, if evolved, could evolve into this type of system. And a good example of this would be a regulatory model in Maryland. And so what Maryland does is they have a regulatory process where they set a budget for a hospital, and if utilization goes up, prices go down. If utilization goes down, prices go up. And so they use these levers to basically hit the budget for a particular hospital. And really the conceptual approach there is, right now, under our current system, healthcare providers gain revenue by doing each individual service, right? So fee for service, if you see a patient, you get paid to see that patient. If you see that patient and you give them an immunization, you get paid to see the patient and give them the immunization. What the budget, so the financial approach that provider offices have to do in order to be sustainable is think about ensuring that they have enough volume. So going back to Elena's slide of volume times price is total spending. When you're getting paid essentially for each individual service, you have to think about making sure that you have enough people coming in to do what you need to do to meet the bottom line, right? To keep the provider organization in business. What the health system budget is attempting to do is kind of flip that on its head and have the provider organization thinking about their financial situation from a fixed budget. So just like I think many of us do in our home budgets, we don't necessarily say, oh, this month I better go out and get 3 more jobs so that I can make enough income to meet my expenses. We tend, most people, to manage the expenses to a set amount of income that comes in every month. And so the purpose really behind the health system budget is to try and create that kind of thinking, financial thinking, in the healthcare system. There are not many health system budgets in the United States that are implemented. In the report, we give you 2 different options. One is Maryland, one is Pennsylvania, and we can talk about all this in a lot more detail. But that's really the sort of the theoretical underpinning of that approach. The second option is setting reimbursement parameters. And so what this looks to do is basically layer on a provider reimbursement regulatory system where we are setting clearer priorities around prices at the policy level. So this could be, we think primary care needs more money. We think, I could pick on any other part of the healthcare system. We think radiology needs less money. I'll pick on radiologists. Sorry, radiologists. And so what you're really then doing in those reimbursement parameters is targeting areas of the health system where you think more investment would lead to better outcomes, or needs more sustainability, or whatever other reason, whatever other problem you're trying to solve, you target more really a floor to that part of the system. But as Sarah mentioned, in order to keep it budget neutral or to not see consumer premiums and cost sharing increase, you would have to have a countervailing decrease to some other part of the system. So when it's the math is fairly basic in the sense that if you're paying somebody more and you don't want the consumer's premium to go up, somebody else needs to get paid less or less of an increase. So we have several options looking at how you could do that in different regulatory processes, in hospital budgets, and rate review, in ACO regulation. And then the third option is, and I should say there are other states that do do this either through their insurance process, through their contracting, or in other ways. There aren't many states that really do it across the board, but there are states that are kind of picking away at that in different parts of the health sector.
So Robin, would Rhode Island fall into that through sort of the regulatory process?
Absolutely.
Yeah. So, and just so the committee understands that on the health system budgeting piece, I did talk with one of the regulators from Maryland last year. I think it was during COVID, but it was a very it was an interesting conversation. And this is a nice review. This is really great. Thank you. Keep going.
Sure. And then fee-for-service rate setting is really looking at setting a price for for each service. So it accepts fee-for-service as in its current incarnation, and the regulatory approach would be setting prices primarily, I think, for the commercial sector, although Maryland does set prices for hospitals across all payers, which requires federal permissions and agreements for both Medicaid and Medicare. But in this option, what we looked at primarily was a couple different ways you could approach that. And in particular, when we did our research, we actually talked to a couple different states that have been looking at how to approach some fee-for-service rate setting, as well as some contractors who work with other states doing this, to get a realistic sense of the cost of implementation, for example. And what we really learned is that any state that's seriously thinking about this uses Medicare as a benchmark. So you'll see that the primary option we have there is doing fee-for-service rate setting using Medicare as a benchmark, which then comes with a whole host of Medicare policy that we would basically need to have a way of going through and saying, we like this one, we don't like this one. And that's important because the legislature in the past has not preferred the approach of paying different amounts for different provider sites, and that is a Medicare policy. So, so those are the three high-level different approaches that we came up with. And I think I'll pause now and see what makes sense before I keep talking.
Okay, Madam Chair, now I formulated a couple questions that hopefully are coherent.
Go for it.
If I may. Robin, thank you. That was really helpful, your explanation right there of those three options. I guess one comment and then a question about those three options. It seems like option 3 is what is moving in a direction that we've been trying to move away from. Everything we've heard is we're trying to move away from fee-for-service rates. And so is that true, or is this a different variation of it?
No, I think that is true. We have been trying to move away from fee-for-service rate setting, but we felt it was important to include it because we know that one of the primary drivers behind the report was this concept of paying one amount for the service regardless of who provided it. And this is the most direct and most direct way to do that.
Okay, that makes sense.
Yeah.
So my two other questions, one is, it seems like option 1 and option 2 could be combined, and you could do both in different ways and sort of meet the goals of each of them and balance the pros and cons of each of them by doing them simultaneously.
You could.
That's just my first impression, because
yes,
go ahead.
No, I was going to say, yes, you could. In fact, you could combine any combination of the three. I think that the challenge is in the implementation and the cost, quite frankly, because when you start to layer, it gets a lot more expensive. And so one of the things we wanted to try and do is be very realistic in terms of implementation, so that when you were thinking about it, you had a preliminary price tag as well, because there are some sub options within 2 that we probably could do with minimal resources because it would build off of our current processes. But the real trick in option 1 is figuring out how to make the budget be not theoretical, right? Because right now in hospital budgets, we set a cap on net patient revenue, and we have enforced that by reducing hospital charges to try and get that offsetting to make it a real budget. But that's the hard part. The actual implementation of the enforceability of the budget is the hard part to do in real time, which gets into data issues and really authorities, right? Like Maryland has quite a massive infrastructure to do this in real time. And so I think if that's a direction we want to go in, we need to be willing to invest in it to do it well, because quite frankly, doing it badly can be quite harmful to the healthcare system. And I think right now we already have concerns about the fragility of our system. And so I think that's really the hard part, or the trick to option 1, is figuring out how to do it well and in a nuanced enough way that it actually works as a budget.
Mm-hmm. Yeah,
because unlike the state budget, like the Green Mountain Care Board as the regulator, we don't actually have any of the money, right? So you guys can impact the budget of Medicaid because you have, the state has the actual revenues and the expenses that it can control. In the hospital budget process, it's all in the private sector, and we're not actually moving money around. We don't have the money. So what we can really do is set the policy, which then the private sector follows and moves the money around to follow.
Can I just add a maybe it's not really a question, it's a comment question, but the board doesn't set rates either. So the board listens to DFR and listens to DIVA. Maybe you could talk a little bit about how that rate setting process fits in with this.
Sure. So the only place, and so we Sarah, maybe you can go to the GMCB, or Elena, could you go to, sorry, I can remember who was driving, the GMCB regulatory slide that we had in the appendix there. So we have 4 different regulatory authorities. The first 3 are hospital budget, insurance premium rate review, and the ACO certification and budget. And we do have some rate setting authority which has not been implemented to date. So that authority was included in the initial statutory charge of the Green Mountain Care Board in 2011 when the board was created. And but it wasn't resourced, because when the board was initially resourced, essentially we took staff and funding from the regulator in existence at that time, which was banking, insurance, securities, and healthcare administration, and moved people over to the board to do it in a fairly budget neutral, inexpensive way. So that piece of it was never resourced. So it hasn't truly been implemented. And that was intended to be a provider side reimbursement regulatory authority. Where we do currently set rates is in the hospital budget process, where we set typically a cap on charges, hospital charges. That cap that we set for each hospital impacts primarily what their negotiation between the hospital and the insurer in terms of their inpatient and outpatient services. It really doesn't impact professional fees, because those are not reimbursed based on the hospital charges. So we do that in that process, and it does set kind of a cap on the negotiation. And then we check in rate review for the insured population how that's playing into premiums.
Okay, can I ask a couple more questions, Madam Chair? I don't know what your timeline is.
No,
okay.
Go right ahead. I mean, listen. We need to take some time with this. I think it's really fundamental to understanding.
Yeah, absolutely.
Forward. Yeah.
So, one of the things that you guys were asked by us to do this report because we were trying to find options for how to set rates, right? And this is, because one of the things as you're going through this that seems missing, and I think it's missing, I think it's missing because this is of what we asked you to do, or what the legislature asked you to do, is there's very little conversation in all of this about patients and serving patients. And one of the reasons why option 2 seems, a little, that I like it a little bit more is because it does have the ability to really focus on patient needs and prioritizing certain services that patient needs, like primary care or oral health or whatever it is that we set as a priority based on health outcomes and based on population health. And the other thing it doesn't seem to have in it, and maybe you get to this, or maybe we didn't ask you this, is that there are some types of patients. I come from school finance, and so that's where my brain goes. There are some types of students that are more expensive to educate because of their background or their current living situation or whatever, or their needs. And so that's what we're attempting to do with the school finance formula, is to try to acknowledge that. And it seems to me that there are patients that are harder and more expensive to serve and care for. Obviously older patients with chronic health care issues, et cetera. And it doesn't seem to me that there's any conversation within any of these models about the different types of patients to serve. And maybe there are, and I'm just not getting it yet. It seems like option 2 might be the one. And I see Elena wanting to say something, so I'll stop talking.
It's funny because I give education parallels all the time. I came from special education finance, so I appreciate that perspective. No, and I think that's the point we were hoping we made in the beginning, but maybe it wasn't super clear. Any of these options, I mean, I think fee for service less than the first 2 should and can address quality. We just did not go down that path because it's another layer that should be added. So both like Maryland has a quality component to its health system's budget, and they can prioritize those needs as you described and think about how they can shift between kind of moving towards prevention as well. I think Pennsylvania is a little bit more because there's this population focus, but I think as we dig deeper into the way that you can construct each of these policy options, it will become more clear how to make those connections. But we didn't, we were on a short timeline, so we tried to pick kind of like, where do we go first? And we thought that was kind of the obvious next step, that we could certainly be more thoughtful. But I think like you said, in these first 2 options, it's certainly something that could be designed and taken into account.
Yeah, yes. I think it would be helpful to just layer on that, because I mean, what I try to do from, in education finance is have it a student-centered approach to how do we fund schools. And I'd really like to see a patient-centered focus on how we fund healthcare. And this seems so focused on providers. And obviously we want providers to not go out of business and continue to provide and do all that. I don't want to make doctors feel like I don't care about them, but I really care about serving patients and want to make sure that our approach is as patient focused as possible.
And that's exactly, I think, the point of moving towards population focused payment models, is that you're paying to keep a person healthy rather than paying for all kinds of services and incentivizing volume. And so having that provider perspective and sustainable perspective is important, because we need access, and their sustainability is an important predictor of access. But we also need to think about which services we need to keep people healthy and how do we incentivize those. So it's really, you need to adopt a systems approach to solve this problem. You can't piecemeal your way out of it. You have to really think about all of the goals. And at some point there may be priorities that have to be determined to say, we really care about this first and then this second, because like we said, it's really hard to maximize all at the same time. But
right.
So
thank you. That's helpful.
Let me just interject a little bit, that the whole concept of value-based payment is to have some quality metric to evaluate the outcomes for the patient. So I mean, and if you layer that on, if you just have the metric and you still have fee for service, you really haven't accomplished the goal of improving the clinical treatment for the patient or of the patient. So, and included in that, so, you know, with or without an ACO, the goal is to have the care management process, let's say from the hospital or from the medical home to the community service, and to ensure that that's seamless, and that a a, a, a value-based payment would cover some of that care or all of that care. So it's you're right. I mean, it doesn't look like there's patient here, but for me, it really does get to the concept that if you're paying fee for service, period, you're not necessarily having an inclusive, quality-based treatment of the patient. Oh, there we go. Sarah, I think, who's next? I don't know where you are in your presentation. We've got about 9 minutes left.
I think this is actually a good place to just pause for further conversation, or if you want us to go back through any of the previous slides, I think that would probably make sense.
Okay.
Could I actually add something related to Senator Hardy's previous question?
Sure.
I'm so sorry to interrupt. One of the things that I just want to note is that for all of these options, for any of these options, there's a lot going on at kind of the sub-regulatory level. So, you know, there's a very common thing in healthcare are risk adjustment models that do exactly what you're saying, Senator Hardy, that look at a patient's, you know, characteristics, whether that's chronic illnesses or age, or you know, social determinants of health and things like housing and you know, transportation and food access, and or whatever it may be. That can help, you know, target the actual payment amounts to make sure that we're thinking about the population that a provider serves at the health system budget level, or even that, you know, can be used to adjust fee for service payments. So there are kind of existing modeling tools that can help us assess potential or likely cost and target resources to where they're needed to best serve patients. And that those tools can kind of can be integrated into most of these options, if not all of them. So I just want to say there's kind of like the payments themselves are, there's so much nuance there, but the high level regulatory options can kind of take those priorities into account.
Yeah, for me, whether we have a fee for service, if we had strictly fee for service, then a provider, whether it's a hospital or an independent provider, would have to just have ongoing procedures and labs and other procedures with a patient in order to cover the costs of that patient. And so if it's a patient who has some chronic needs, or it's a pediatric patient coming in for multiple visits over a year, then how many patients, would the physician need to have, and then how many treatments, or how many visits would the patient need to have? By having a value-based payment, then you can assess the best clinical practice and then provide a reimbursement that covers the cost of that patient per member per month or for a year. One of the questions that we've had in committee has been, have those value-based reimbursement rates been the same for providers in a clinically affiliated organization versus those that might be in a more independent organization? How does that work? So, and I don't know if you can talk a little about that.
Sure. So so there are two different layers of value-based payments to consider when thinking about that. One are the Blueprint for Health per member per month payments that go to primary care, and the payments that the Blueprint sends to the community health teams. And those are Those payments are the same regardless of provider affiliation. The second set of payments go through the Accountable Care Organization. And so the Accountable Care Organization has per member per month payments that go to a variety of providers, certainly primary care, but also there are per patient payments that go to designated agencies and other types of providers who are working with that patient and helping to manage care, or in some cases are the lead care manager. But there's also a payment model that the Accountable Care Organization has established for independent providers called comprehensive, it's CPR, comprehensive, is it
Payment
primary
reform.
care?
Payment reform.
Payment
Yeah.
reform. It's a little bit of a generic name, but the purpose behind that model was to create a capitated payment essentially for primary care that has enhanced value-based care components. So for independent providers who have chosen to participate in that program, they actually financially are in a superior position than providers who are in the regular payment models, which would include the affiliated providers. So there is an option which actually pays independents more if they're able to take on capitation. Capitation does not necessarily work for every office, depending on their size. And the board has had some panels involving providers who talked about how that particular program enabled them, for example, to embed a mental health specialist in their office. Or do things in a more creative way. So that may be a program that you'd be interested in getting more information about. We do get every 6 months, I believe, Elena can correct me if I'm wrong, but I believe every 6 months, the Green Mountain Care Board gets an update on that program. So we can also provide you with those written updates that we receive as the regulator of the ACO, if that would be helpful. And again, I should say in that process, because the state's approach has been a provider-led approach, our ACO budget review process includes really considerations around it being provider-led. So we're supposed to balance overseeing the process with allowing it to be provider-led, and which means that we don't dictate those payment models. We review them, we raise questions, we make sure they're being implemented in the way that they were discussed to us. We monitor changes over time, but given that balancing act in our statute, dictating it has been really a step that's a little bit beyond our current authority, I would say.
So Robin, I'm wondering if we could take the screen down now that we're in sort of discussion mode for a minute. We can always put it back up. I know you had you had another slide there, said next steps. And did you want to talk about that first?
No, I would say that the next steps really for you and us together is to continue doing a deeper dive into each of the 3 options at your pleasure, and to, whatever your desire is on that, we're happy to come back and do that deeper dive and then talk about kind of paths to move forward depending on, your pleasure.
Okay. I think you're hearing the concerns about ensuring that there's a focus on patient outcomes. I think that's very clear, and I think it stands for all of us. And it is embedded in our healthcare reform efforts. Then how I think we would like to hear more, I think in particular on option 2 and some on option 1 as well. We want to hear a little bit about a hospital financial sustainability. And I know we're going to get a report from you on hospital financial sustainability in the fall. I've lost touch of when that is exactly. Do you have
September
a sense?
1st.
Is it December 1st?
September 1st.
September 1st, right. Or unless unless there's a need to move it back. And I know the hospitals are interested in having it moved back, but we'll see how that goes. That would be great.
Yeah.
But I think that the second option really kind of makes sense based on what our committee is interested in and on value-based payments. Can you say a little bit about your regulatory responsibilities as compared with what's going on with FQHCs and how FQHCs fit into the whole scheme of things?
Sure,
And
maybe I'll start.
maybe a review of what an FQHC is, a really high level, brief help.
Sure, I'll start and Sarah Kinsler can jump in because she's deeper in FQHC regulation than me. So a federally qualified health center is a health center which has applied for and received basically a certification is probably not quite the right word, from the federal government to receive federal funding to provide a sliding scale patient price. And so the purpose behind federally qualified health centers are to ensure that there's primary care in underserved areas. Vermont has been very fortunate in terms of getting approval for federally qualified health centers, and it allows for the uninsured and underinsured to receive affordable primary care because that entity receives additional grant monies from the federal government to support that work. Those entities are regulated through the federal government, HRSA, and a majority of their revenue is really from the Medicaid program, as well as HRSA. They do see some commercial payments as well. And what we had seen in prior pay parity reports is actually for their commercial population, they tend to be paid really the least out of all the different provider types. So what in this report, because the revenue is so heavily Medicaid focused, and because they're so heavily regulated at the federal level, we did not do a deep dive into how to include them in these different payment options. We would need to do that, I think, to understand how it all fits together. But given really the extensive nature of the report to begin with, we didn't really have the time to do a deep dive into one provider type. Sarah, did anything I missed?
Yeah, sure. The couple of things that I would add are that the federal government actually sets out a kind of mandatory payment methodology for federally qualified health centers called the prospective payment system. There are also a lot of other things, unfortunately, that are called the prospective payment system. But PPS, as it's known, really sets out Medicaid reimbursement for federally qualified health centers because they, all over the country, this is true, they tend to serve so many individuals who have coverage through Medicaid. And the PPS rates are an encounter rate, which covers all of the services that you might see in one doctor's visit. So you get one rate for a visit where the services might vary vastly. That said, a key piece that I think it's important to mention related to the PPS rate is that it also is meant to encompass what are known as wraparound services. So knowing that FQHCs tend to serve a lot of Medicaid beneficiaries, uninsured, underinsured, there's a lot of kind of social services wraparound that's meant to help folks work through insurance coverage issues, all of the kind of social determinants of health that might impact their health or their health care. So oftentimes there are embedded social workers that are, helping folks work through housing issues or food access or whatever it might be. So the PPS rate is kind of in recognition, as well as the federal grant money are both kind of in recognition that FQHCs not only serve a population that could benefit from those wraparound services, but that they do so more than other providers. And regarding our regulation of federally qualified health centers, I'll say that there's a lot that's kind of not waivable from a federal perspective, and I won't pretend to be an expert on that, but
we haven't really gotten into the federal permissions for different options, but that would be something we'd want to discuss as we move
Yeah.
forward.
My baseline knowledge is that there's a lot that's kind of not negotiable and not waivable under federal law. So there are challenges with implementing payment reforms with FQHCs, and you kind of have to go through a different level of federal approval. And I know that by state is certainly far more expert on that than I am at this point.
Yeah, we'll get them in ultimately.
About any option that would touch it.
And I see your hand, Senator. The trying to align service options and rules becomes that much more complex entering into the federal government. And so it would seem that maybe, would it be helpful to have, for at least the primary care wraparound services that we offer in the state, would there be any benefit? It's just an open question. Would there be a benefit to adhering to the FQHC model and the federal rules? Would it make our lives simpler?
I think we would need to really take a look at that. And I think to have an informed response, to be frank. But I think the other piece you'd want to think through, and I would want to think through, is how that interfaces with the blueprint, because that's really what the blueprint is attempting to do, is provide funding for those wraparound services.
Right.
And so that question, I think, should be considered as part and parcel with the blueprint, because either it makes the blueprint redundant, or it would really, you'd really want to discuss those hand in glove.
Right. Yes. Thank you. It's a question I know that's going to be asked, but that the blueprint on one hand, and on the other hand, how much autonomy does the state give up in its in oversight and regulation of its healthcare system? Not that we don't like our FQHCs. In fact, they're awesome. At least I know the one in my area is terrific. So, Senator Hardy.
Thank you, Madam Chair. It's unfortunate that our colleague, Senator Cummings, isn't here. I serve with her on finance, and it's become kind of a joke in finance that Senator Hardy and Senator Cummings like flowcharts. And so we keep asking witnesses for them. So now they're sort of coming in knowing that we're going to ask them for a flowchart. But I almost feel like and so I'm like trying to visualize, as you were talking, Robin, about the different types of payments that already exist, like the blueprint payments and the FQHC payments and insurance payments and yada, yada. There's just so many. And I'm like, oh, I don't even think you could possibly put this on a flow chart. But if you are able
at one
to,
point,
pardon me?
Steve Capel at one point, Nolan may remember this, had attempted to flow chart it. We'll see if we can dig that up. It's very complex.
I know. I was like,
listen,
it would have to be like a poster sized piece of paper or something, but I could decorate my walls with it. If there is anything like that, that would be helpful for me to visualize it, because that helps me to learn how things flow, and then also just sort of talking about it is because I'm an extrovert. But Nolan just left. The question,
he probably has that flow chart.
You have the flow chart for me, Nolan?
Oh, what are we talking about? Are we talking about the churn chart?
Steve Capel.
No, I love the churn chart, but no, do you remember when Steve tried to map out all the different payments in the healthcare system? It was a very complicated chart. I'm pretty sure I could find it, or I could ask Steve. I'm sure he has it. We also do have a chart that kind of highlights the ACO payment models that the ACO have prepared. So we can, I think if between those two, we might be able to come up with something.
Okay.
We
That would be great.
We might have that ACO flow chart in some of the, we didn't get handouts this year. Like we did get a folder from the ACO last year when we visited them, or 2 years ago when we visited them. But I'm wondering, they would probably have something like that. It is helpful.
Okay.
It is
I have, and my other question is, so you're presenting us with options of things that we could do. Is there is there a deadline coming up that we have to make a decision? Is there some statutory requirement? If we do nothing, it's just we're going to continue with the current system, which isn't quite working the way we want it to? Or yeah, it sounds like that's the issue. It's not like there's no deadline for us to have to do something, or
No,
something bad will happen. Okay.
just the status quo. So whether or not
Yeah.
you define the status quo as bad.
Yeah. Well, yeah, fair point, Robin.
And the sustainability planning for hospitals was kind of put forth because there are some imminent concerns, and we saw, what happened in Springfield and the bankruptcy. So, there's no deadline, but there are also, our system is challenged. And
yeah, there's system urgency.
Yes.
But it's not like by September 15th of 2021, we were supposed to have figured this out or something like that.
No.
Okay.
That depends on who you are. I would like to figure it out.
Well, yeah, obviously we'd like to figure it out sooner rather than, but I also think because it's so complicated, because there are new members on this committee, I think
that's why we're going slow, Senator. We're going to go slowly. The whole hospital thing, though, was the kind of the motivator and the generator for looking at least at the number one, looking at hospital sustainability, and then visiting with folks from Maryland and other states is really important. And then on Health Reform Oversight Committee, we brought in a consultant from Stanford. His report is still up on the HROC webpage. And so hospitals have been hit really hard during the pandemic, not just because of elective procedures, that too, but also the extent to which they have worked overtime, and that includes nurses that we talked about earlier. So,
may I add one other caveat to the dates? So there is one other date might be important to keep in mind, and that's the proposal for a subsequent agreement. So if we didn't get there, but some of these may require Medicare to
approval
participate, right? So
yeah, yes, we'll have to.
And when is that, Elena?
December 31st of this year is the deadline included in the agreement.
Okay.
But that's really to start, just to give the federal government kind of a first shot at what we are thinking about. It's not that will be the start of negotiations, not the end of negotiations.
Right. And you are working on that with Ina Backus and AHS.
Yes.
Right. So it'll be important for us to know any decisions that you would like us to make. We'll be talking about decisions that we would like us to make, but it would be helpful to know what thoughts you have and how we might help with that.
Absolutely. And I think, it's been, as you all know, it's been a challenging time with COVID, and, AHS has really been under the gun, standing up vaccine clinics and all the work that they've been doing. So, we've been trying to support them in whatever way we can in terms of their COVID response.
Okay. Senator Hooker, any questions or any question or comment would be helpful.
So the December 30th, 31st date has to do with the upcoming renegotiation of the contract for the ACO. Is that?
It's a proposal for a subsequent agreement, so it doesn't specify what needs to be included, but.
Okay.
So can you talk?
I'm sure as you started to talk about yesterday, that there's a distinction between the all-payer model agreement, which is the agreement between the state and the federal government, and the ACO itself and their program and their contract with different payers. And so really the all-payer model agreement is meant to set a high-level approach for cost containment and quality improvement for the state as a whole, and has particular regulatory authorities for the board that are related to Medicare. So it's really that higher level agreement, which has the deadline of the 31st.
maybe, Robin, from your perspective, elaborate a little bit on that agreement and what has been included and what we might be seeing going forward.
Sure. Well, I should do my disclaimer here, where I am one of 5 board members and the board has not discussed it, which means the board itself does not have a position yet, because as a public body like you, we do all our discussions in public. So what you're hearing now is really just Robin Lunge. And I think part of the reason probably that Senator Lyon is asking me this question is I was involved in the first negotiation with Governor Shumlin and Al Gobey, who is then chair of the Green Mountain Care Board, as well as others, including Ina was staffing that effort, as well as Michael Costa, who at the time was working in my office. So in that initial agreement.
Just FYI, I did send the initial report. I think it was a 2019 report out to the committee. So we do have that initial report on how things were going, but go ahead.
Great. Yeah. So with the all-payer model agreement, it really tried to set forth a target for total spending. Total cost of care is the technical term in the agreement for the state, which sought to align healthcare spending with previous state economic growth, which is, quite frankly, a very ambitious task, because healthcare is, I'm sure you know, grows much faster than the state's economy. But really the guiding principle was Vermonters need to be able to afford their healthcare costs, and to do that, we need to have healthcare costs and economic growth be more aligned. And so the target there is between 3.5 and 4.3%, which is 2 different historic time periods of Vermont economic growth, looking backwards at the time we were negotiating. And so I think as the board is hearing the most recent update on quality and costs next week, so we'll have a better sense and a better update next week. But we've, as a state, been trying to hold to that as our guiding, or as a regulatory board, holding to that as our guiding principle. It influences our thinking in the hospital budget process, in rate review, and all of our regulatory models. So the state is currently just above that 4.3 at 4.4%. Although we do expect, given the reduced utilization in the pandemic, that may fall back down. The agreement basically is a 5-year agreement, and that cost containment is meant to be a 5-year look. So while we monitor it year to year, we're really looking for how we did at the end of the performance period, which is the 5-year period. I think the key point I would make about the total cost of care is that it was an ambitious endeavor. And so regardless of whether or not we make it, I think if we are even close, we've really, I think that's an achievement, because if you look at particular hospital spending prior to 2014, our inpatient and outpatient growth rates were really in the 7-8%, and we're down in the 3 to 4%. So that is an achievement as a state. On the quality side, there's been some ups and downs, but also, as I'm sure Elena will chime in, the quality performance is a little bit tough given the shifts in the population. So one of the challenges with a model getting ramped up is that your population that's covered by that model will change every year, which means you're comparing apples and oranges year over year. So that's something that we've struggled with a little bit, but as that population gets more stable, we'd have more and better information.
And the other thing on quality and population health is many of these are 10, 15, 20 lifetime year goals. So you're not going to see a change in social determinants of health overnight, because these are really trying to get at root causes that take a long time to unravel.
So with
Oh no, did Senator Lyons freeze up, or did I freeze up?
I think Senator Lyons.
Madam Chair, you're frozen.
She said she was having unstable broadband
Internet, yeah.
Oh no.
Hey, Nellie, do you know what the situation is with Senator Lyons? I don't know what she was going to ask. I wish I could read her mind, but since she's not here, Cheryl or Senator Terenzini or Senator Hooker, do you have other questions for our witnesses? Because we are probably in our last 5 minutes before we have to leave to get to the floor.
No, but this has been really helpful. I mean, this is a lot of information. So
Yes. Yeah. You
Senator
recognize.
Terenzini, do you have anything you want to ask?
I was just going to thank everyone for the presentation. It was very thorough, and it's always good to hear about and learn. So thanks for being here.
Happy to be here and happy to come back at your pleasure.
Yeah, I'm sure that we'll want to have you back for part 2, because your slide did say part 1. So I'm assuming the scintillating conclusion in part 2 will be soon. Do any of you have anything to add?
No, I think we're happy to be here and we look forward to coming back.
Great. And Nolan, I see you've been on here. Do you have any questions or anything you want to add?
No, I'm good. I know how to contact them.
Good. Nellie, have you heard from Ginny about, I don't want to end the meeting if she's planning on coming back, but I also don't want to just hang out here.
Yeah, I have not heard anything from her. My guess is that she was having an internet burp, as you mentioned.
Okay. Well, given that it's 11:21 and we're going to be on the floor in a few minutes, if nobody has any other questions, then maybe we'll just end the meeting and we'll have you back. And I'm sure the chair will have more questions for you at that time, as we all will. And in the meantime, if you have the flow chart, I'd love to, poster it on my wall. Thank you so much, everyone, and have a good weekend.
Thank you. You